Hello everyone, I am Dr. Ankit, working as a reader in the Department of Oral Maxillofacial Surgery at Babu Banarsidass College of Dental Sciences, Babu Banarsidass University, Lucknow. The topic for today's lecture is oral cancer. Let's start with the content of the lecture: clinical evaluation, radiographic evaluation, and histopathological evaluation. As you all know, head and neck cancer comprises of 25% of all cancer in India and one of the most common cause of mortality and morbidity in males. Oral cavity is that part of aerodigestive tract which extend from mucocutaneous junction at the vermilion border of the lip to the anterior surface of the facial arch. Over 30,000 new cases of cancer of oral cavity every year. Of them, 90% are squamous cell carcinomas. More common in male, tongue and floor of the mouth are the most common site for squamous cell carcinoma. Retromolar trigone and the buccal mucosa are the most frequent encounter primary site in those parts of the world where tobacco chewing and chewing of betel nut are most prevalent, like in India. There are 8 steps in screening of oral cancers. The 8 sites you can go for: gingiva, mucosa, lip, buccal mucosa, posterior gingiva, hard palate, tonsillar area, ventral surface of the tongue, lateral border of the tongue, and the floor of the mouth. All patients who are suspected for head and neck carcinoma should be evaluated by head and neck surgeon, oncologist, and should be recorded the following. Detailed history of the patient is required, disease related information, detailed history of habits and addiction, medical and family history, include any prior malignancies, and clinical examination. Clinical examination I'll cover in the detail in the next part of the lecture. Then imaging, which are required. Then histopathological diagnosis, like biopsy. Now, difference between the clinical feature of benign and malignant tumor. Size, malignant tumor are large in size while benign tumor are small. Growth is slow in the benign tumor while fast in the malignant tumor. Pain is present in the malignant tumor while absent in benign tumor. Hemorrhage, very common in malignant but not usual in benign tumor. Ulceration are absent in benign tumor while present in malignant. Paresthesia is commonly occur in the malignant tumor while not occur in the benign tumor. Induration are present in the malignant tumor while absent in the benign tumor. Symptoms. Malignant tumor are always symptomatic while benign tumor are asymptomatic. Metastasis, very common in malignant tumor and usually absent in the benign tumor. Let's start with the different type of tumors. There are types: papilloma, so slow growing, exophytic growth, cauliflower-like growth, finger-like projection, few millimeter to centimeter in diameter, pedunculated or sessile, squamous cell carcinoma, that is most common in older age male. Lower lip is the most common site. Second most common site is the lateral border of the tongue, as you can see in the second picture. Then symptoms of tongue cancer: pain when chewing or swallowing, inflammation, mouth ulceration that does not heal and does not respond to the local treatment, lumps on the tongue, patches in your mouth. These are the symptoms of tongue cancer. Let's start with patient with primary malignant tumor in the oral cavity with the varying symptoms according to the location of the primary tumor. Early stage tumor most often present as non-healing ulcer with varying degree of pain and some occasional episode of bleeding. Superficial ulceration and early tumor are often assumed to be non-neoplastic. Any tumor which lack of response to the conservative treatment or the presence of loose teeth shows great suspicion of malignancy and required biopsy to reach a definitive diagnosis. Difficulty in mastication and speech often developed with the size of the tumor. In a very advanced lesion, can feel local pain, referred otalgia, and restriction in the mobility of the tongue. Excessive salivation, impairment in the phase of the swelling will result in pooling of the saliva and distortion of the speech of the dead patient. Impairment of mastication and deglutition. Loss of weight because of restricted diet. Advanced lesion with invasion of the mandible leading to paresthesia, produce anesthesia of the skin of the chin. Halitosis with fungating necrosis, as you can see in the second picture. When the trismus is present, lesion of the floor of the mouth may cause obstruction of the opening of the Warthen's duct and lead to obstructive submandibular silidinitis. Their palpable cervical lymph node tumor may be ulcerative, exophytic, endophytic, and proliferative. Ulcerative lesions are irregular edges in duration of the underlying soft tissue, while exophytic lesions are cauliflower-like irregular growing, flat pink to pinkish white proliferative lesion, while red to pink velvety flat lesion, superficially invasive carcinoma or carcinoma in situ. Bleeding from the surface raises the suspicion of the neoplasm. Verrucous carcinoma, white heaped up lesion with varying degree of keratin debris, as you can see in the two pictures. Exophytic lesion, very small surface component but have a substantial amount of soft tissue involvement beneath the surface. It's an endophytic lesion. Then the tumor of the minor salivary gland, most common in the hard palate because of the high density of minor salivary glands. Mucosal melanoma are pigmented or non-pigmented. As you can see, these are pigmented mucosal melanoma. Brown-black pigmented lesion is a characteristic feature of mucosal melanoma. Now come to the TNM staging. T is not stand from primary lesion cannot be assessed. T0, no evidence of primary lesion. TIS means carcinoma in situ. T1, lesion 2 cm or less in greater diameter, while T2 is lesion more than 2 cm but less than 4 cm in diameter. T3, lesion more than 4 cm in diameter. One more is T4. T4 staging, T4A and T4B. T4A, lesion invades through the cortical bone into the deep extrinsic muscle of the tongue like genioglossus, hyoglossus, palatoglossus, and styloglossus, maxillary sinus or skin of the face. Lesion invade masticatory space, pterygoid plate or skull base or encircle internal carotid artery are considered as T4B lesion. Now, N staging, N naught stand for regional lymph node cannot be assessed. N0, no regional lymph node metastasis. N1, metastasis in a single ipsilateral lymph node less than 3 cm in greater diameter. N2A, metastasis in the single ipsilateral lymph node more than 3 cm but less than 6 cm in greater diameter. N2B, metastasis in a multiple ipsilateral lymph node more than 6 cm in greater diameter. Now N2C is bilateral or a contralateral node, not more than 6 cm in greater diameter. While N3, if metastasis in any lymph node greater than 6 cm in diameter is considered as N3. Now M staging, M0, distance metastasis cannot be assessed. M0, no distance metastasis. M1 is the presence of distance metastasis. Now stage 4, A, B and C. Stage A4, 4A is operable while 4B is inoperable. 4C is metastatic cancer. Now, Sloan-Kettering cancer system classification, these give the label of lymph node. This classification is important to understand the neck dissection in the later part of the lecture. The subgroups 1A and 1B, that is submental, as you can see in the diagram. 1A is the submental group of lymph node, while 1B is the submandibular group of lymph node. 2 is the upper jugular lymph node. 2 is again divided into 2A and 2B. That is anterior to spinal accessory nerve. 1 is posterior to the spinal accessory nerve. Then the middle jugular lymph node. Then the lower jugular lymph node. Lower jugular is again divided into 4A and 4B. Lower jugular behind the clavicular head, and 1 is in the anterior behind the sternal head. 5A posterior triangle lymph node. 5B is the posterior triangle lymph node. 6 is the lymph node in the anterior triangle, or 7 is the supraesternal lymph node. Now come to the detail of this. This is label 1A and 1B. This is label 2, that is upper jugular. Label 3, that is middle jugular. Label 4, that is lower jugular. Lymph node in the posterior triangle, that is bounded by anteriorly by the posterior border of the sternocleidoid muscle. And in the posterior border, it is bounded by the anterior border of the trapezius and inferiorly by the clavicle. Then lymph node of the anterior triangle. And now Sloan-Kettering cancer system has described the labeling system of cervical lymph node. Label 1, that is submental lymph node. The lymph node between the anterior belly of the digastric and the cephaloid of hyoid 1 is called submental group of lymph node or 1A. 1V is the submandibular group of lymph node. Lymph node from the anterior and the posterior belly of digastric muscle and the inferior border of the inferior border of the body of the mandible. Now, upper jugular lymph node, upper portion of the internal jugular vein, that is up to the bifurcation of the carotid, from the upper portion of the internal jugular to the bifurcation of carotid, now labeled 3, from the bifurcation of the carotid to the omohyoid muscle or to the inferior border of the cricoid cartilage. Label 4, from the lower third of the internal jugular vein, from the inferior border of the label 3 up to the clavicle. Now label 5, that is lymph node in the posterior triangle, bounded by the posterior border of the sternocleidomastoid, anterior border of the trapezius, and below is the clavicle. Lymph node in the anterior triangle or the central compartment lymph node. Lymph node boundaries are hyoid 1 to the supraesternal notch. Now level 7, that is lymph node from the supraesternal notch to the innominate artery. Supraesternal notch to innominate artery is called level 7. Now come to the imaging in the head and neck cancer. Why imaging is required? 20% of the neoplasm in head and neck region may be small and superficial and imaging is not required. Remaining 80%, the primary role of the imaging is to evaluate the deep extent of the disease and to guide for biopsy or for treatment planning also. Which modalities, now question come into your mind, which modality to be used for the treatment of oral cancer? MRI or CT scan. The simple rule is MRI in the suprahyoid neck while CT scan in the infrahyoid neck to reach a definitive diagnosis. MRI you can go for suprahyoid neck, which include nasopharynx, oropharynx, base of the tongue, anterior tongue and the hard palate, salivary gland, paranasal sinuses, cavernous sinuses, dura and the brain. Now, paranasal sinuses. For paranasal sinuses, imaging with MRI is preferred along with CT. This is the baseline investigation. For thyroid, you can go for ultrasound in highly sensitive node detection. For salivary gland, MRI. Now, histopathological evaluation or biopsy to reach a definitive diagnosis for a patient of cancer. Now, definition, according to Richard, removal of the tissue from a living being for gross and microscopic examination, chemical and bacterial analysis, or a combination of all. Classification, if a tissue piece is taken, excisional biopsy, incisional biopsy, curating, or a frozen section. Tissue core, fine needle cutting biopsy, true cut needle biopsy, Wim-Silverman needle biopsy. Cell aspiration, we can go ahead for fine needle aspiration cytology, guided FNAC, scraping, brushing biopsy, exfoliation cytology. Indication for biopsy, any lesion that persists for more than 2 weeks with no apparent etiological basis, any inflammatory lesion that does not respond to the local treatment. Any persistent tumor suspected being a neoplasm, inflammatory changes of unknown reason, persistent hyperkeratotic changes, lesion that interfere with local function, any tissue surgically excised should be examined for biopsy. Bone lesion not specifically identified by clinical and radiographic finding, any lesion that has a characteristic of malignancy. Contraindication of biopsy, lesion caused by recent trauma for ambiguous lesion, frank malignancies, varicose vascular lesions, proximity to lesion to the vital structure, patient with bleeding disorder, post-irradiated patient, compromised general health of the patient. Now, characteristic of lesion that raise the suspicion of malignancy, like erythroplasia, lesion is totally red or has a speckled red appearance. Ulceration, lesion is ulcerated or present as an ulcer. Duration, Lesion has persistent more than 2 weeks. Growth rate, lesion exhibit rapid growth. If bleeding is by on gentle manipulation, in duration, lesion in surrounding tissue is formed to touch fixation. Lesion field attached to the adjacent structure. Now come to the frozen section. Frozen section is a technique of freezing the tissue and it is useful during the surgery. It make an immediate surgical and therapeutic decision during the surgery. Determine whether the lesion is malignant or benign. Adequacy of clear margin after resection by frozen section. Now, what is sentinel lymph node? It's important. Sentinel lymph node is the first lymph node to which the cancer cell is likely to spread, or a primary lymph node where the cancer cells spread is called sentinel lymph node. That's why sentinel lymph node biopsy is a procedure in which lymph node is removed and examined to determine whether cancer cells are present or not. It is based on the idea that cancer cells spread metastasize in an orderly way from the primary tumor to the sentinel lymph node, then to the other lymph node. Now, general guideline for selecting a treatment modality for cancer: stage 1 and 2, single modality, surgery or radiotherapy. Stage 3 and 4, combined modality is used, like surgery, radiotherapy with or without chemotherapy. Second is chemotherapy plus radiotherapy. Now, selection of modality depend on the site of the cancer, subsite of the cancer. Now, assessment of resectability. Tumor involving the following structure are technically unresectable. T4B, that is unresectable. Erosion of the pterygoid plate, sphenoid bone, widening of the foramen oval, extension to the superior nasopharynx or deep extension into Eustachian tube, lateral nasopharyngeal wall. Cancer or the growth which encashment to the internal carotid artery more than 270 degree, involvement of mediastinal structure, involvement of prevertebral fascia or cervical fascia. Now, principles of resection. The most important thing is a 3-dimension. The base should be taken carefully into the account before excision. In continued neck dissection with direct extension of the primary into the neck. What is adequate margin? Adequate margin, the margin which needs to be removed along with the cancer cells or the suspected end of that lesion. 1.5 to 2 centimeter. Clear margin is more than 0.5 centimeter. Closed margin is less than 0.5 centimeter. Now, frozen section is section confirmation for margin may be done for if the facility is available. Now, classification of neck dissection, it is mostly based on the Sloan-Kettering cancer system classification. And now the comprehensive neck dissection. What is radical neck dissection? Removal of the all cervical lymph node from level 1 to 5 with sacrification of 3 important structures: spinal accessory, sternocleidomastoid, or internal jugular vein. That is called radical neck dissection. What is modified radical neck dissection? In a modified radical neck dissection, removal of the same lymph node 1 to 5 along with removal of the one or more lymphatic tissue. These are 3: spinal accessory nerve, internal jugular, and the sternocleidomastoid muscle. The nomenclature, as you have to write, MRND, that is modified radical neck dissection with preservation of internal jugular vein and spinal accessory nerve. In an older time, we use MRND type 1, 2, and 3. That is very confusing. 1 means you have to preserve spinal accessory, then in 2 you have to preserve internal jugular, in 3 you have to preserve sternocleidomastoid. Nowadays, this is eradicated and new system, that is MRND, and the structure you want to preserve, you should be mentioned in a bracket that preserving these structure during the surgery. Now, what is extended neck dissection? Removal of the lymph node level 1 to 6 along with removal of the external carotid artery. It's called extended neck dissection. Selective neck dissection, supraomoid neck dissection. In a supraomoid neck dissection, the procedure consists of lymph node removal of lymph node level 1, 2, and 3. And one more, extended supraomoid neck dissection, removal of level 1, 2, 3, and 4 is recommended for primary cancer of the lateral border of the oral tongue. Now, the jugular neck dissection, It consists of lymph node level 2, 3, and 4. Now, selective neck dissection. Selective neck dissection is denoted the level and sublevel of the lymph node for the oral cancer. Lymph node level 1 to 3 at higher risk for metastasis. Therefore, selected neck dissection will be performed at a staging procedure. Thank you.